I've now got the pleasure of inviting Dr. Anna Minchcombe to the stage. Some of you that came last year will remember Anna, but unfortunately she had to zoom in last time, whereas we now have the real thing with us today. So Anna's going to talk to us about clinical trials. So.
Hello, everybody. Thank you very much for having me back. That's always a good sign, I think. So hopefully I'm going to give you some new data this year, build on what we talked about last year. So I'm Dr. Anna Minchcombe. I work in the Royal Marsden in Sutton, where I treat patients with lung cancer, and I also run clinical trials. Here are my disclosures. So what am I going to cover? I'm going to talk about developments in trials for ALK-positive lung cancer. I am going to touch a little bit on how to access clinical trials when you would want to do so and how you would do that as well in context of the trials that are ongoing in the UK at the moment. So just a bit of background information to orientate yourself as I go through some trial examples. We have a standard way of referring to clinical trials as phase 1, phase 2, or phase 3 trials. And these trials are all fairly different. So a phase 1 trial is the first stage of testing a new drug. The drug's been tested in a laboratory, in some cells sat in a dish, and in some animals. But then after that, the drugs need to be tested in real-life patients, and that's in a phase 1 trial. So a phase 1 trial has a relatively small number of patients. And in that trial, what we're trying to do is find out what the right dose of a drug is and look at the side effects of the drug. So in that course of that trial, the dosage of the drug will be increased in each group of patients that go on a clinical trial. Phase 1 trials are really labour-intensive for a participant. There's lots of appointments in hospital for monitoring because safety has to be of paramount importance when you're investigating a new drug for the first time. If a drug passes a phase 1 trial, then it progresses to a phase 2 trial. And that's a trial that is in slightly larger groups of patients and is really looking at the response rate in a particular subgroup of patients. So of relevance today, often in looking at how the drug works specifically in types of ALK-positive lung cancer. If a phase 2 is passed, then a drug may be tested in a phase 3 trial. And that's when the drug is compared to either a placebo or a dummy drug or another treatment. So you could imagine that a phase 3 trial in ALK lung cancer might be that the new ALK testing drug is compared to a chemotherapy, for example, and patients will be randomly assigned to the group, either of the new drug or the comparator. Phase 3 trials aren't always run. They take large numbers of patients, hundreds and hundreds of patients sometimes. And what I really want to point out, because I'm often asked this, is what does that mean? What do these phases of trials mean for a patient? Well, a patient enters a clinical trial that's available and open at the time. So a drug will progress through phase 1 to phase 3 over sometimes a decade. So really, what part of a trial a patient enters depends on what trial is open at the time. So it might be that a patient could enter a phase 2 of a particular drug that was open at the current time, but then the trial would close and the next opportunity to access this drug might be when a phase 3 opens a year or two later. I hope that makes sense. It's about sort of dipping into the drug development process and what's available when it's needed. So I'm going to go through some specific examples that I think are the most interesting developments going on at the moment. And some of the drugs I'm going to be discussing are drugs which are designed only for ALK-positive cancers. But I'm also going to discuss some drugs that are designed for non-small cell lung cancer as a whole. So maybe being tested in patients without ALK-positive lung cancer, with other types of lung cancer, that have a relevance for ALK-positive cancer. You'll see what I mean. So the kind of a headline trial, I think, to discuss is a trial of a tyrosine kinase inhibitor, TKI, small molecule. These are drugs which are similar to the tablet drugs that are used on the NHS at the moment for ALK-positive lung cancer, brigatinib, lorlatinib. This example is a 4th generation of this class of drug. So I think you've got a talk on this tomorrow as well, so I'm slightly stealing their thunder, and I'm going to do so happily. So I got in here first, I can discuss it first. The drug is NVL-655. There's been 2 presentations of data from this trial, one last year and then an update relatively recently at ESMO, which was in Barcelona a couple of weeks ago. This drug has received FDA breakthrough designation, and what that means is it's been recognised as showing potential in this particular space. The trial investigating NVL-655 is called the ALCOVE-1 study, and that's been recruiting patients in the UK for quite a while now. As I go through the talk, I've put in the NCT number for each trial. So the NCT number is the unique identifier that will identify these trials. So if you want to go away and Google it later and look up, then you can be sure, if you look up the NCT number, you'll be looking at the right trial. And that's also relevant if you're going and searching online for other trials as well. So the phase 1 portion of this trial, the dose-finding part, is already completed. And I was an investigator at that, in that part of the trial. It's now opened up the phase 2 part. So going back, this is now, we know what the right dose is, and the trial is now looking at the response rate, how well the drug works in patients with ALK-positive lung cancer. It's open at a number of different centres in the UK, including the Marsden. So in the phase 1 part of this trial, various doses of a drug were looked at, ranging from 15 milligrams, which is an absolutely tiny dose, but it's the dose you start on these trials to make sure you're giving a very, very safe dose, and increased up to 200 milligrams. And the recommended phase 2 dose, so the dose that now is going to be used for further testing in the phase 2 trial, is 150 milligrams. So the information we have, the up-to-date information is on from 133 patients participating in that trial. So obviously the most important thing is, did the drug work? Well, it did. So responses were seen in 38% of patients. When I mean response, I mean that the cancer shrunk down by a predefined amount. So 38% of patients had a shrinkage of their cancer. When looking at those patients who had ALK resistance mutations, I'm really pleased Riaz went through that, because that's great. I was trying to think of how to explain it within my time frame, and I don't need to now because he gave a great explanation of that. Those patients who had mutations that were picked up, which were the reason their original drug stopped working, they responded in 55% of cases. And if we look at the patients who had lorlatinib, 35% of those responded. So what this is saying is this is an active drug, and it seems to work in groups of patients who have had previous treatments with ALK inhibitors. It's really important in these trials to unpick whether these drugs work in the brain. For obvious reasons, brain metastases are common. That it's important to treat them in terms of controlling any symptoms that might develop. And this is an MRI scan just taken from the trial. Can't get the laser pointer to work. It's okay. You can see a little yellow arrow on there showing a small metastases in the brain, and on scans it is shrunk down in size. And if you note the time written at the top of that third little black square, that's 10 months in. So the responses that were seen were fairly what we describe as durable. So patients could respond for many months. But what about side effects? The side effects seemed reasonably tolerable. The most common ones I've written down there. So about 12% of patients had some degree of nausea. About over 30% had changes in their liver tests. So This is more changes that the doctor picked up on the blood tests, but didn't result in any liver damage or any symptoms, and got better on monitoring. So a sort of blood test problem rather than anything that causes symptoms. A peculiar symptom of, they call dyschezia, taste changes, metallic taste, unpleasant taste, and there was some constipation as well. Important to say, 2% of patients stop the drug due to side effects. So the majority of patients were able to continue on drug with extra medication alongside to control any side effects they were having. Okay. So one other key area of development is to look at how we can improve the response to this group of drugs, the ALK inhibitors. And one way of doing that is to combine the ALK inhibitor with another drug. And so there's lots of trials going on at the moment combining existing ALK inhibitors, lorlatinib, brigatinib, whatever, with either a second ALK inhibitor or other different inhibitors of different proteins. Of the flow chart that Riaz showed, taking out different proteins involved in the signaling of a cell. All these trials, as far as I'm aware, are actually recruiting in the US. So this is really an area to watch. Watch this space, because we should get results of those coming out in the next months or years. I haven't seen any results yet, and as far as I know, I don't think that any of the trials that I certainly flagged up are outside of the US. So I'm going to change tack now and talk about another class of drugs. These are called the antibody-drug conjugates. And there is a huge amount of fuss about these drugs at the moment. They take a bit of explaining. So chemotherapy is a fairly blunt tool. Chemotherapy works, but it is a toxin. It is a poison to cancer cells, but it's not specific to cancer cells, and so causes the side effects that we're familiar with from chemotherapy when it also affects the normal cells of the body. So nausea, hair loss, for example. So antibody-drug conjugates are a potential new way to give chemotherapy or chemotherapy-like drugs. So what it has is it has a chemotherapy payload that is attached by a linker to an antibody. An antibody is a protein and that has two sides to it. It has one side that you can stick something onto. You have the other side, which will stick onto a part of a cell in the body. Okay, so the part of a cell that it will stick to is called a target. Oh my goodness, everyone's looking at me like I'm bonkers. Okay, so these targets are proteins that are found on cells in our body. And there's millions and millions of them. Some of these particular proteins or targets are only found on cancer cells and aren't found on normal cells. So if you can find this target, this protein, that is only found on a cancer cell and is not found on a normal cell, and you can design an antibody that will attach only to that target and not to anything else, and attach a chemotherapy to it, in theory, you can deliver your chemotherapy directly to your cancer cell, and it won't attach or go anywhere near any of the normal cells in the body. So in theory, you'll deliver chemotherapy directly to the cancer cell and not cause any side effects, because you won't target any of the cells in the body. Yeah, okay. That's a theory. Of course, in practice, these things are always more complicated, and these particular drugs, though exciting, definitely do cause side effects. And that either is because the little chemotherapy bit comes off the antibody and circulates around the body, or because once the antibody-drug conjugate goes directly to the cancer cell, it can come out the cell again, and it can attack a few cells, presumably near the cancer cell. But anyway, there's 1,000,001 different antibody-drug conjugates around, and we're recruiting very well in lung cancer trials in general. One slight thing to say is that there's a lot of work to be done with these particular drugs. There have been trials testing whether these drugs are better than chemotherapy in non-small cell lung cancer against docetaxel chemotherapy. So far, none of these trials have come out as positive, as showing better than a docetaxel. The targets that are being investigated in lung cancer are quite a lot of them, but the main ones that I would sort of pick up as potentially the ones that might be making a difference in the future are TROP2, MET, and HER2 and HER3. The one I wanted to mention is datopotamab deruxtecan, or Dato-DXd. This is a trial targeting TROP2. That's the target found on the cancer cell. There's the NCT number there. This trial is no longer recruiting, but was presented at a meeting last year. And this trial was looking at whether the drug worked in patients with non-small cell lung cancer with genomic alterations. So that includes patients with EGFR mutations and ALK rearrangements. So 25% of patients who entered this trial had ALK-positive non-small cell lung cancer. The response rates, so of the patients who entered trial, how many patients had a shrinkage of their cancer, the response rate was 35.8%. 23.5% in patients with ALK-positive lung cancer. Bearing in mind, only 34 patients with ALK-positive lung cancer were included in this trial, so quite small numbers. The diagram down the bottom here, does it work, is one of the standard plots that is produced when you're looking at trial data. On the left-hand side of a graph is the percent change in the tumour. Each little line, each little purpley or blue line represents the information from one patient on the trial. So you can see on the right-hand side of the graph, those patients didn't have a response to the drug. The cancer simply grew. But as you move towards the right-hand side, you can see that all those patients had a response in their cancer, and their cancer shrunk. Importantly, again, what happened with brain metastases? Well, we don't have full information about this because this has just been presented at a conference. We haven't got the full published data yet. But the authors who presented this study said that about half of the patients who had brain metastases, there was only 18 patients, had a reduction in the size of their brain metastases. So this is the sort of data, this is the sort of information we get from this sort of trial. Small numbers of patients. The drug works in some patients, the drug works in the brain, but what we don't yet know is how well that drug works in larger groups of patients and how it compares to the other treatment options we have available. But hopefully we will have the answer to that question at some point. The study at the top is that drug with its other name, its number name, and this drug is being compared to docetaxel, to chemotherapy, in patients who have had treatment for non-small cell lung cancer, who have ALK rearrangements, ALK-positive lung cancer, or other subtypes of lung cancer, such as EGFR lung cancer. And there's many, many others of these drugs being tested around the world and in the UK. I just flagged up one here, the sacituzumab tirumotecan, so they don't make it easy with the names. This is another trial that's recruiting in and around London and the UK, again, which allows in patients with EGFR and with ALK lung cancer. So the next question you might ask is, well, you can target particular parts of the cancer cell. What about targeting ALK with these antibody-drug conjugates? And the simple answer to that is yes, in theory, you can target ALK with these antibody-drug conjugates, but really, these particular drugs have been designed, but they're being tested in other types of ALK-positive cancers, such as brain tumours and in pediatric cancers. And that's because where the ALK sits in ALK-positive lung cancer is within the cancer cell rather than sticking out the cancer cell surface, so it can't be easily accessible by this antibody-drug conjugate. I hope that makes sense. So there'll be other targets within ALK-positive lung cancer which ADCs, antibody-drug conjugates, might work in, but those specific to ALK, the ALK sits in the wrong place, and so it can't be used. So the third main type of drugs I'm going to discuss is immunotherapy. So the body's immune system, one of its roles is to identify cells in our body that are wrong, that are corrupt, that are not functioning properly. And that includes, obviously, cells in infections, so in viruses and in infected cells of the body. In theory, the immune system should also recognize cancer cells and destroy them. Unfortunately, one of the ways that cancer cells have developed, is that they've developed ways to hide from the body's immune system. And we know in lung cancer as a whole that if we can give immunotherapies that unmask the cancer cells and allow the immune system to recognize the cancer cells and kill them, then these immunotherapies can have quite a good effect. And they have pretty much revolutionized the treatment of non-small cell lung cancer as a whole. Immunotherapies have worked less well in ALK-positive lung cancer for a sort of variety of biological reasons, but essentially because ALK-positive lung cancer is not a smoking-related cancer, the immunotherapy doesn't work. So there's a lot of work going on at the moment to identify different types of immunotherapy that may work in ALK-positive lung cancer. And the one that everybody talks about is cancer vaccines. And I just had a conversation outside with somebody asking about this particular question. And I certainly get, and I'm sure all oncologists do, I get inquiries about cancer vaccines on a very regular basis now. And this is because the NHS Cancer Vaccine Launchpad has been launched in the UK. And this is a platform that has received funding at quite a high level to try and speed up access of patients with all types of cancer to vaccine therapy in the UK. What are cancer vaccines? So the exact mechanisms of cancer vaccines is certainly beyond me. But let me just sort of explain that what you're actually trying to do with a cancer vaccine is to try and utilize the body's immune system, the T cells of the body's immune system, to fight the cancer. And the way you do that is you introduce into the body's T cells in the body, the circulating immune cells, part of the cancer, either a protein or part of a cancer cell itself, into the T cells, which makes the T cells recognize the cancer cells. And the one type of vaccine which is sort of being prioritized, because there's many types of vaccines, there's virus vaccines, there's peptide-based vaccines, there's cell-based vaccines. The one that's being prioritized is what's called an mRNA vaccine. An mRNA vaccine is attractive for two main reasons compared to other types of vaccines. One is that some of the other types of vaccines, you have to have a particular immune type for it to work. So we've all got immune types. Similar to our blood groups, you might be have a group A blood group. We have a similar categorization for our immune system, which obviously is not often tested, but it can be tested. And so many vaccines are specific for one HLA subtype. And so therefore, to enter a trial of that particular type of vaccine, a patient would have to have a blood test to find out their immune group, similar to a blood group. mRNA vaccines don't have that restriction. And the way these work is that the mRNA, and Riaz mentioned this earlier on, a subtype of DNA is taken from the cancer cell, is packaged up, so that when it's put back into the body of the patient, it is taken up by the immune cell, and the immune cell will therefore recognize the cancer that the mRNA originally came from. So this is particular to the patient. It's highly personalized. You give it to somebody else, it wouldn't work. Which all sounds very exciting. The practicalities of these trials is complex. The main trial running at the moment is the MOBISE trial. NCT number is there. It is recruiting in the UK at the moment, certainly in UCL, but only a very small number of patients will end up going on these trials for complexity and for simply the relative smallness of a trial compared to the population of patients with solid tumours in the UK. And we wait to see the results. I guess the results will be a long time off coming, but will be certainly headline news when they come. What about specific for ALK? So, again, could you design a vaccine that would be specific for ALK? Yes, you can. And this article was out a few years ago showing how scientists are able to, certainly in the testing part before using in patients, design vaccines specific for ALK. And I know that the ALK positive charity as a whole is funding work in this area. So no trials yet out as far as I know, but certainly are in development certainly in the US. A second type of immunotherapy is being tested in ALK-positive lung cancer called tumor-infiltrating lymphocytes, or TILs. So this is another complex immunotherapy approach. It relies on taking a biopsy from of a patient and looking at that biopsy fresh and taking out any immune cells sat in the biopsy. Now, I've said that immunotherapy doesn't work very well in ALK-positive lung cancer, but the body does try. And so within the biopsy from a patient sample, there will be a few immune cells that have managed to get into the cancer and are trying to do their work. So what you can do is take these immune cells and grow them in a lab, and you can expand their population so you've got many more of them. And then you could just put them back into the patient. You could give them a fusion and give those increasing numbers of white cells, immune cells, back to the patient. Unfortunately, before you give these white cells back, you have to give chemotherapy to try and reduce the competition for these white cells so they have a best chance of working and attacking the cancer. So you could see from this this process that these are intensive therapies, certainly not for everybody. And there are trials going on at the moment, again in ALK-positive lung cancer in the UK and globally, looking at this approach to see whether it will have any benefit. There's also one look in towards the east, outside of the UK, in Korea, looking at a combination of a similar type of approach called NK cell therapy. So that's the summary of drug trials. And as you can see, we have sort of one clear drug that is perhaps making a difference at the moment. The rest of the drugs that I've discussed are really more on the horizon, showing potential, but we haven't yet got concrete data about how these drugs will work in the future. I did want to spend a minute going slightly off topic and talk about trials of radiotherapy, with a big proviso that I'm not a radiotherapy doctor. I do drug trials and give drug treatments. So this will be a slightly simplistic view, but I think this is really a hot topic. So in patients who have their ALK-positive lung cancer controlled by drugs, but then one part of the cancer begins to grow, and that could be, for example, in the brain, with brain metastases, or outside of the brain, another part of the body with one area growing, then we are faced with a little bit of a conundrum at the moment, because there's two approaches to that. The first approach is perhaps the most straightforward, to say, well, we have an area of cancer growing, therefore the drug's not working. Let's stop the drug and move on to a different drug. But the other approach, now that we have very specific ways of giving high doses of radiotherapy, is to say, well, we've only got one area of cancer growing, why don't we give some radiotherapy to the one area of cancer that's growing and continue on the existing drug treatment? And that feels instinctively like quite an attractive approach, especially if somebody's been on a drug, a tablet, they're tolerating well, got a good quality of life. Can we prolong the length of time they're on that drug for? Though that instinctively feels quite right, and we also know from looking at what happens in practice that in most cases is probably quite a safe approach, we don't yet really have any comparison of which of those approaches is better for the patient in the long term. Which, for what period of time, if we compare, do people stay well and stable on their treatment for? There was one trial that tried to look at this, called the STOP trial. That was quite complicated and showed that there was no difference between patients who were assigned either to continue their drug treatment with radiotherapy or to move on to a different drug treatment without radiotherapy. But the reason this was difficult, because, well, what do you think happened? The patients who were assigned to change their drug treatment and not have radiotherapy said, thank you very much, I don't want to participate, and went off and got their radiotherapy elsewhere anyway. So, you know, which you can see why that would happen. So the results of that, I don't think, are really gold standard. They don't give us a full answer. But we do have two trials that have been recruited and are now, we're waiting for results of, called, one's the HALT trial run here in the UK, and then another one from Canada. So I personally am really looking out for these results, because I think, though this is not a drug trial, these sorts of results will really help inform our practice and help us think about what are the best options in that situation when we've got some areas of the cancer growing, but not all. So for the last minute, I just wanted to clarify with a little bit of a sanity check. The range of drugs, the range of trials is absolutely bewildering. It's bewildering for anyone. If they look on the internet, you can find a huge amount. It's very difficult to sift through and see what trials are available. There's only limited information available online. Sometimes trials will look like they're open, but they're actually shut, or there's no slots available on the trial. Of course, some drugs may sound very exciting, but they may not actually work in practice. And I just wanted to mention how you can think about accessing clinical trials. I mentioned this last year, so forgive me if this is already fresh in your mind. I've got a real vested interest in this because I see patients every week for clinical trials. When do you want to access clinical trials? When the cancer's growing. Almost all clinical trials say the cancer needs to be growing before a patient enters a trial, so there's no point looking at clinical trials really before the cancer is actually growing. Where might you access clinical trials? There's many centres around the whole of the UK. Some of the phase 1 trials are run in specialist centres in the ECMC network. If accessing a clinical trial, do think about whether you would want to travel to that centre on a regular basis. There's no point having a 200-mile commute to a clinical trial. It would probably be not feasible. How can you access? Talk to your oncologist. Talk to this group as a whole. Detailed awareness of what options are available in the UK is tricky, and it's really okay to get a referral to a trial centre without a particular trial in mind. You don't have to do all the grunt work beforehand. It's okay to come to a trial centre and say, what have you got? And to mention that when patients come for a clinical trial, there's a process to go through. So there's an assessment by the research team. This is certainly how we run it in my centre. If there's a slot available on a trial, it's allocated to a patient. They have an information sheet and a very, very detailed consenting procedure where they find out all about the trial, including information not available in the public domain about how the trial has been to date and then we start trial. So it can be a several-week time frame to actually get on trial. And when going for a clinical trial, quiz the oncologist. Why are they recommending this drug? Has it shown potential in ALK-positive cancer or just lung cancer as a whole? What phase is the trial at? How long has it been running? What's been the experience to date? Has there been any problems, any safety concerns? What's the schedule of visits look like? How many times a week do you need to come? Thank you very much.
Anyone got any questions for Anna? Yes. Becky. Oh, we get a mic to Becky. Lovely, thank you.
Hiya.
Hello.
I just wanted to ask, you've mentioned all these different options with like vaccines, TILs, ADCs, but as far as I'm aware, there's nothing available other than Novalent. I've asked about it with my oncologist. So do you know about anything, because you mentioned the TILs and you said that it's recruiting globally in the UK. I did ask about that to my oncologist, Professor Middleton, and he said that wasn't an option. I've literally been told my only option is chemo. So when we're talking about all this hope with all these things that are coming, but I'm just being told no.
Yeah. I absolutely understand that. And I mean, I think, like I was saying, the complexity of what is available, when you look online or you look at the sources, there are many trials that are potentially open, but it depends on if there's slots available, if it's actually open yet or delayed to be opening, or if it's already completed and we're just waiting for results to come out. So yes, I agree that on a day-to-day basis, though it might appear that there's lots of different options for patients to access, it's more complex than that. Certainly, I know there are some of the phase 3 trials are certainly open, but then we've got the detailed problems of the inclusion. So one of the phase 3 trials is compared to chemotherapy. So if a patient went for that trial, then they might be allocated to the docetaxel arm. So they may be going for a trial, but actually not access the new drug, but be accessing the comparator arm of an existing drug, such as chemotherapy. So yes, I sympathise that though there appears to be a lot of excitement on paper, accessing trials on a day-to-day basis is difficult.
Do you know of anything that's going on at the moment at the Royal Marsden?
Let's have a chat later.
Also, the Tropion Lung 05, when's that going to be available? Because I spoke to Professor Middleton, and you mentioned it on there as well, and that looked quite promising. But as far as I'm aware, it's not actually been approved over here yet.
No, it's not approved over here yet. No. And the trials are ongoing in it, so I don't think we're anywhere near approval for that yet.
Okay, thank you.
Have we got any more questions? Yes,
we
have.
Am I right to assume that phase 3 trials are less demanding for the patient than the phase 2? And if yes, is it reasonable for someone with a busy life? I'm a full-time doctor, I never stopped. Is it reasonable to join a phase 3 trial if offered at some point?
I think you need to go and have a specific conversation about it. You know, in general, phase 1s are really complex and can be really hard work for a participant. Phase 2s may be quite reasonable sometimes, you know, especially with a tablet drug. You know, it may be more, the schedule may be more akin to having something like chemotherapy. But it's really variable. And for each trial, there's a schedule of events, a table, which lays it out really detailed. You know, each day, what needs to be done. It depends on journey time. It depends on how intense each appointment is. You know, whether it's a simple blood test and a doctor review is very different from staying in for an intravenous, administration of drug. So it's really variable. But yes, in general, your phase 3 is less onerous for a participant than a phase 1.
Just talking about coming out of trials and then into general medical usage, I'm pretty clear on what happens with a new drug in terms of it tends to go to FDA approval first, and then it'll go to regional approvals in other parts of the world, and that's MHRA and NICE here in the UK.
Yeah.
For trials which aren't specifically, so I'm thinking back, I was actually thinking about the whole trial here, where it's not, there's no new treatments, it's just treatments being given in a slightly different way. If those trials are successful, how does that then change clinical practice? Does it still have to go through NICE, or is it something that then oncologists can start practicing straight away?
Great question. So the slight difference between MHRA and NICE is that MHRA is about the licensing of a drug. You know, is it approved? Can we safely use it? NICE is about funding. So we may have a licensed drug that is not approved by NICE because it's not felt to be cost effective enough. Therefore, we're not allowed to prescribe it in the NHS, even though it's a licensed drug. So your question about what happens with things like radiotherapy trials is if it was shown to be effective, that giving a certain type of, and I'm not a radiation oncologist, a certain type of expensive high-dose radiotherapy improved outcomes for patients, but they would still need to go through a commissioning process so that it could be funded, because they're expensive procedures.
NICE.
Yeah. So it's expensive procedures. If you can show in a trial that existing practice is that you already have a pathway for improves outcomes, then that's even better. That's quids. Then we just have information to help inform what we're doing already, and that's great.
I was just curious, you said that the immunotherapy is not so effective for ALK+, because it's a mainly non-smoking cancer. So what makes it not so effective? If I were to start smoking, would...
Oh my goodness! That is such a great question, and I'm going to use that in future talks. Definitely don't start smoking. So what it is with the smoking cancers is that smoking over a period of a lifetime causes damage to the DNA of the cells. And so the constant damage to the DNA of the cells causes something called neoantigen presentation. What basically it means is that the immune system gets quite lots of stimulation because there's lots of dirt, there's lots of damage to DNA, which prods the immune system so that the immune system can recognize the cancer. So it only needs a little push from immunotherapy to start working. So it's about this DNA damage causing something called neoantigens, which causes the immune system to be a little bit better able to recognize it. But definitely don't start smoking. And other groups are in the same. So ALK-positive lung cancer is similar to ALK-positive lung cancer in that it doesn't respond well to immunotherapy.
I think we've run out of questions. They're excellent. Thank you very much. So I'd just like to say thank you very much to Dr. Minchcombe for coming along today. And I think she's given us a lot of food for thought and given us a lot of hope that there are things on the horizon, and we need to keep our eyes open and our ears open and keep exploring what's available. So thank you very much indeed.